Good morning, everyone. We'll be getting started in about 2 minutes. We have 3 speakers for you this morning. Please understand that there is about a 15 to 20-second delay with questions once we start the question portion. If you want to go ahead and start feeding questions in the comments section, please feel free. You also can feed questions to me on my cell phone, which is 502-650-2624. And it's 9 o'clock. We'll go ahead and get started. My name is Jill Scott, Communications and Marketing here at Louisville. We are going to be announcing today phase 1 from the Coulomb Unity Project. With us today are Dr. Rooney Nagar, Dr. Kenneth Palmer, Dr. John Klein, all of whom are co-investigators of the project. As I mentioned, we'll be taking questions in the comment section of the YouTube broadcast. I also take questions on my cell phone, 502-650-2624. And with that, I'll turn it over to Dr. Rooney Nagar. Dr. Nagar.
Well, good morning. Thank you, Jill. Can you hear me well?
Yes.
So thank you for being here. This is, I think, an exciting day for us. We've been working on this project for some time now. We started sometime in March with the idea that even though there was general testing in the community that was offered by a variety of locations, we needed to test for the virus in our community in a more systematic manner so that we can know who was being infected, what is happening with the rates of infection community-wide. So in April, we launched the project. This is called the Co-Immunity Project, which was announced by the governor. And this is a collaboration with the Louisville Healthcare CEO Council and the University of Louisville in order to develop a good insight into the rates of COVID-19 in the city of Louisville. So when we first started, we had the first phase of the project, which we call phase 1 of the Co-Immunity Project. And this phase was to understand the extent of the infection workers. The healthcare workers are an important sector of our community and are particularly critical in this scenario, which we need them to be healthy and robust, to be able to withstand this pandemic and to take care of the people who do get infected. So the results we are sort of reporting today are from the phase 1 of the Co-Immunity Project, which are primarily of the University of Louisville Hospital system. And for this sort of activity, what we did was we actually requested our healthcare workers to do their own tests. So we gave them kits for which they could get us blood samples and samples of the swabs so that then we can deliver it back to us. And then we could took them to the lab and measured the antibody against the virus and the RNA of the virus to look for both those who are infected and those who have been infected. So our total sort of individuals that participated in this project was about 1,300 to 1,400 people. Unfortunately, some of the data we lost because of not of some of the sample collection issues, but regardless, we got good data from at least 1,372 participants. And as I mentioned, we tested both the antibody and the virus, the active viral infection in these individuals. And what we found was of these, only 2 were testing positive for the PCR, while the remaining and an additional 14 had positive antibody tests. So what this means is that we have within our healthcare workers a relatively low level of infection, which was this we can speak for maybe in the month of May, and the total number of people who were exposed also remains low, but of course significantly higher because as we know, the direct active virus that we measure in the PCR test tells us about who is currently infected, whereas the antibody tells us that someone who has been infected in the past, because it takes several weeks for the antibodies to develop. And so this gives us sort of some view of the level of spread that has been within our healthcare community, which in some ways is good news because it means that the rates of infection within our hospitals is low, and that this rate is sort of comparable to the types of rates of infection that have been reported elsewhere. Although there have been very few studies that have actually measured or evaluated or tested healthcare workers exclusively, some of the data that we have, there was a paper, I believe, from Germany, which showed that only about 1.6, 1.5% people were infected, were antibody positive, or there was total rates of infection in the healthcare system. And so we found a similar sort of incidence of the total disease here within our system. So which means 2 things. It means that the type of precautions that we have been taking, particularly our healthcare workers with their equipment and with social distancing, have been working, and that we could see the results of that we have managed to contain the spread of the infection to low levels. And we can say that it would be going forward that we would be able to then, with the help of these data, see what is happening continually with our healthcare workers, and if there are changes in the rates of infection, maybe because of a downturn, there are less people getting infected, or if there is a resurge, then we would be able to compare our data to be able to gauge if there is a sudden increase in the spread of the virus among healthcare workers. So I think these data are valuable. We are still analyzing, which is trying to understand where and at what places most people are likely to have been infected. We have some initial results which suggest that there may be certain areas, maybe high-risk areas or professions, that individuals who are working in those scenarios are more likely to be infected. But we need to do much more work. We will do this. We have done this last month, but we need to do this again. We need to be able to continuously monitor what is happening with the healthcare workers, and if they are getting higher or low rates of infection. So we will repeat this in about 4 to 6 weeks. We would go back and then test some of the same people, and we will of course invite other new participants to keep monitoring and assessing the level of infection in our hospitals and surrounding areas. So this would be what we again would be a phase 1 of the project. The phase 2, which we began last week, would be then to test the general community. And so for that, using the lessons that we've learned from Co-Immunity 1 and our work with the healthcare workers, we would test around 2,400 people as a random sample around the county. And we would look at different areas of the city to ensure that we are sampling individuals and participants who belong to different parts of the city. We want to develop an inclusive set of data which has a proportional representation of different age groups, different races, and gender. So we are doing, as we speak, we are doing that now. We have 3 centers open today. They would be finishing, and we've been doing this for a week. We will finish today, and that maybe we'll have results in a week or 10 days. But for now, I think this is, to me, seems like good news that we've been able to, at least in some sense, contain the spread of the virus and stem the infection, at least within the healthcare workers. This is a sort of a partnership, as you can imagine. There are lots of people involved. We have over 50 or 60 individuals who've been, at the university, who've been participating in the project. We have our staff, our faculty. We have our physicians and nurses, as well as our students who have contributed and volunteered to do this work. It takes a team effort to do all of this together, and we are very fortunate to have had support to be able to do this. I've been talking to many cities, and it's difficult for people to find support, especially when the early part of this pandemic, where we did not have sort of resources from the federal government. We generated our own resources, and we are very grateful to the Jewish Heritage Fund for Excellence for supporting this project, at least the phase 1 of the co-immunity project, which had made it possible for us to do this work. But this is only, I would think, an interim result. We are, as I said, continuing to do that. We will repeat co-immunity 1 again in 4 to 6 weeks. We will finish our co-immunity 2 and do that again in about 8 weeks, so that we would have some sort of a radar, or sort of a viral radar, to be able to gauge how the infection is going up or down. One of the main ideas with this project was also to identify individuals who actually would have a positive antibody test, and as you might have heard, that the plasma from such individuals could be useful in a recovery of those with most severe symptoms. And so we are going to be testing the individuals who are positive with the antibodies to see whether that their level and the strength of the antibodies is high enough to be able to donate plasma to others. And then we would set up sort of a process in which they would be able to donate their plasma for those most in need, so that at the same time that we are looking at the community and trying to understand infections, we are all trying to set up a set of resources that would be of use to others, particularly those who have very severe infections and very limited options in terms of recovery. To tell you more about how we are doing this and what this partnership means and how we actually got to do it, the only reason we could do it was in collaboration with our Center for Predictive Medicine, and Dr. Kenneth Palmer is here, and I will hand it over to him to tell us about his views of these results and how we got about to doing all of this. So, Kenneth?
Thank you very much, Aruni. I would like to express my grateful thanks to all the volunteers from the University of Louisville Hospital who participated in the study. Their kind donation of samples really was what made this study possible, and we're really grateful to all the volunteers. The testing, the laboratory testing, was all conducted at the Center for Predictive Medicine, the Regional Biocontainment Laboratory on the Shelby campus. I would also like to reiterate that this testing was only made possible through a very kind gift from the Jewish Heritage Fund for Excellence, which allowed us to set up the testing capabilities at the Regional Biocontainment Lab. Our virus testing group here was based on a process developed and refined by Dr. Dong-Hoon Chung, who is a member of our faculty in the Center for Predictive Medicine, and the virus testing group was led by Amanda Lasnik. The antibody testing methods were developed by one of our faculty members, Dr. Crystal Homorsky, and her team worked on processing all of the blood samples to measure antibody levels. In looking at the antibodies, what we were primarily looking for were antibodies in the blood from volunteers that recognized the spike protein on the surface of the SARS coronavirus 2, or the virus that causes COVID-19. I'm sure many of you have seen a structure of the virus, or a cartoon of the virus, that shows the spike protein forming part of the corona around the virus. And we know now that antibodies that bind to that spike protein are the antibodies that would mediate protection from infection. So we were really focusing on antibodies, looking to see whether people had antibodies against the spike protein. We were also specifically looking to see whether there were antibodies against a small domain of the spike protein, which is called the receptor binding domain, because we know that if there are antibodies that recognize this receptor binding domain, that will stop the virus from entering the cell. So in the blood samples, we measured antibody levels against the spike and against the receptor binding domain. As Dr. Batnago said, we found that there were 14 volunteers in our cohort of 1,372 that have measurable antibody levels against the spike and against the receptor binding protein, receptor binding domain. So this might predict virus neutralizing antibody or protective antibody levels. We went further because the Regional Biocontainment Lab has the containment facilities necessary to work with the SARS coronavirus 2, that's biosafety level 3 laboratories. We went further to test neutralizing antibody levels in the blood of the volunteers who tested positive. And we did indeed find that they were producing antibodies that were neutralizing the virus. And we look forward to tracking the levels of neutralizing antibodies in those volunteers and any other people that we find positive in the Community 1 and Community 2 studies. So as I said, I'm very grateful to the volunteers. I'm very grateful to all the philanthropy that the Louisville community provided in order for us to do this study, and would be happy to answer any questions. The next person on the agenda to speak is Dr. John Klein, who is the Vice Dean for Research, School of Medicine, and I'll turn it over to him.
Thanks, Kenneth. I actually just want to take a minute to take us back to the origins of this pandemic, to put in perspective the speed at which science is moving, and in particular, the accomplishment of phase 1 of the Co-Immunity Project in that context. It was on December 29th that an unknown pneumonia began to affect people in the city of Wuhan. It was only on January 7th that the Chinese CDC was able to isolate the virus and identify it as the SARS coronavirus 2. Remarkably, only 3 days later, on January 10th, the Chinese scientists and CDC published the genetic sequence of this virus. Remarkably, because the Center for Predictive has the highest level of biocontainment, and our regional biocontainment laboratory is one of only 12 in the entire country that's supported to do this type of work. Dr. Palmer was able to obtain virus stocks by February 10th, which allowed him to begin to develop not only cultures of the virus, but also a PCR-based test, which ultimately in early March became the only clinical test in Jefferson County that was available to hospitals, not only in the U of L system, but throughout the system. Since then, commercial tests have become available, and more testing is being done. But it was because we had the regional biocontainment laboratory and the ability to store the virus, that we were able to begin doing the sort of testing that has now led to co-immunity 1, phase 1, co-immunity phase 2, hopefully very soon. I think it points out the tremendous value of research intensive, or what we call R1 universities, the ability to take large assets such as the Center for Predictive Medicine and the Christina Lee Brown Environmental Institute, bring them together and put them to work on problems that are of major import to society. So I'm incredibly proud of these two institutes and centers. I think the university has done a good job of bringing its assets to bear on this pandemic. I'm very proud to not only be a co-investigator on this project, but also I was a participant as one of the healthcare workers at U of L Health. So with that, I think I'll turn it back over to Jill Scoggins and we'll take some questions.
Thank you. I'm not on screen. I hope you hear my voice. We'll take questions now. Please submit questions, as we said earlier, via YouTube chat, or you can text them to me at 502-650-2624. Sorry, I just kind of momentarily blanked out on my own phone number. I do have a question here, and it's for, I'm going to start with you, Dr. Bhatnagar, and if anyone else wants to weigh in, feel free. Talk a little bit more about what the Louisville results tell people in other cities in Kentucky or in the U.S. or even in the world. How is there any extrapolation that we can make with these results to other places?
Well, so like I mentioned, that there have been a couple of studies. I think there was one study in China, and there was a study in Germany that I know of. There may be others that we may have missed, but these studies have shown that the rates of infection among the healthcare workers, and since we are using the antibodies as a sign of exposure, that we could say has been low. And the numbers from Germany compare well with the numbers that we have here in Louisville. So it does suggest that at least for the healthcare workers, that the type of measures installed around the world have worked, and that there have been of course there have been infections and people have been exposed, and there have been deaths among healthcare workers as well. But in general, that the response have been such that so as not to have widespread infection among healthcare workers. So what we would say is we should keep doing on the same things that we've been doing here and elsewhere in a healthcare scenario where we have protection, where people maintain the measures and distances that they do. And so therefore, there is a great need to continue doing what we have been doing. Of course, this scenario is a bit different from what it was early on in the disease, because now we have more or less greater interaction with the general community, with our healthcare workers. Most of outpatient and inpatient patients are there, and they're visiting, and so therefore there is much more interaction than was in the beginning. So I think we need to be careful, and that's why we need to do this again, to be able to make sure that once you open and we have a wide range of patients coming through our doors, that we do not increase infection. But in general, what the lesson for other places in the state and elsewhere in the world is that the system more or less worked.
That's good news. We have another question. The researchers mentioned phase 1 and 2. How many phases are there, and what is the overall duration and purpose of the study?
So for now, we have phases 1 and 2. We're still planning to do other phases, which we might be able to look at the long-term effects of infection of people who actually even recovered, because there are some reports that there could be lingering health issues of people who were infected early on during the course of the pandemic. So phase 1 is the healthcare workers that we just reported. We completed the first part of that, We are going to repeat that every 4 to 6 weeks till December at least. And the phase 2, which is ongoing, and we will repeat that every 8 weeks till December, or the time that our funds or resources run out. These are very resource intensive activities, and so we cannot plan for the long term. But at least I think it's really critical that we have both phase 1 and phase 2 operational and ongoing in the fall, where we anticipate that there may be a resurgence. So that for now.
Good deal. How will we understand if a certain level of antibodies confers immunity? Will this study help answer that question?
I would direct you to Dr. Palmer, who is much more of an expert in antibodies, might tell us what it means.
So that's $64 million question. We hope that a certain titer of neutralizing antibodies will be protective. That's the basis of developing a vaccine. Our study is not currently designed to assess whether people who have neutralizing antibodies are susceptible to subsequent infection, although we may discern that in the subsequent rounds of testing in co-immunity 1 and co-immunity 2, but we are not particularly looking for that. Our study, I don't think, is going to be adequately powered to answer that question. So I think, based on what we know from other viral infections, that the titers of antibodies that we're seeing in our healthcare worker volunteers are good, robust levels of neutralizing antibodies. But at this point, we don't have the data to say that they're going to be protective antibodies. We hope that there will be, but we don't have the data yet.
Yeah, and it's not only that we don't have it. I don't think there's much data out there. I mean, no one has that, right?
Yes.
It's a major issue.
Our study is not designed to answer that question, but yes, as Dr. Bhatnagar says, there's insufficient information out there yet to know what levels of neutralizing antibodies are necessary to protect people against subsequent infection.
Good deal. Thank you. The next question I will handle initially, and then if anybody else wants to chime in, feel free. The question is, which health facilities involve U of L Hospital and any others? The entire project involves the 3 major health systems in Louisville, which of course are Baptist Health, Norton Healthcare, and U of L Health. The study results we're announcing today are for U of L Health only, the U of L hospitals. In the news release that you should be receiving, or should have received a short while ago, it outlines the number of facilities in U of L Health. So we will be announcing the study results from the other facilities later. I don't know if anyone else, you, Dr. Bhatnagar, Dr. Palmer, Dr. Klein, want to add anything to that.
Well, we did test all the major hospitals in the U of L health system, our U of L hospital, the Jewish hospital, and so there was also the St. Mary Elizabeth, the U of L outpatient center, the Springs, U of L East End outpatient, the VA, and other outpatient center that we have here at the University of Louisville. And so even though we don't have much rates of infection, how each of the facilities is doing and whether the rates of infection are higher in some than the others, and who are the people who were exposed. And we are analyzing those results, and we will publish them shortly.
Okay. Thank you. Here's another question. With the reopening of facilities throughout the state occurring now, it's believed that we'll see an uptick in positives, COVID-19 positives. Is that what you see? Are we reopening too early? Have we contained the virus at this point?
Dr. Klein, you have thoughts about that?
Oh, those are policy questions that are beyond the scope of this project. Because we are going to repeat testing through December, what we can say is that if there is an uptick, we will be able to see it. And that's one of the values of this project is while it may just be a snapshot in a moment in time, a single week of individuals testing, by repeating it over time, we'll have a series of snapshots that tell us what the trends are. But that said, testing for antibodies is obviously a trailing indicator of infection, and even testing for the presence of the RNA in the PCR test is still pretty late in the infection process and in the pandemic process. So none of these are going to be leading indicators. Another project that I think we've already announced is our testing of wastewater, of sewage. And that may provide us with a little bit more of an early warning detection system.
Okay, thank you. Have another question. Actually, two questions from WDRB. Is there any breakdown on the types of healthcare workers who were tested? And since the tests were self-administered, are the researchers confident that the test results are accurate? So tell us a little bit about the breakdown on the types of healthcare workers involved, and talk a little about the self-administration of the tests, and are you confident that the results are accurate? I just want to say, if they weren't confident, we wouldn't be announcing them. Go ahead, someone, though. If you could talk a little bit about the breakdown on the types of healthcare workers who were tested.
Right. So we had, during the testing, the healthcare workers administered their own tests, but also filled out a consent form and a questionnaire. And with that, we have self-reported data on what sort of capacity they were working in. We have in our participants, physicians. We had nurses, nurse practitioners, medical physician assistants, phlebotomists, and nursing assistants, and nurses and respiratory therapists. We also asked them to tell us where they worked, whether they were working on the ICU or the CCU, whether they were doing endoscopy, working in a cath lab, excuse me, or labor and delivery, or NICU. So we have the data, and we are still in the process of analyzing those data. We want to see whether certain types of professions or certain places that people work in is more likely to be exposed, or there are areas, or the rates of infections were uniformly distributed throughout the healthcare system. So once we do the analysis, we'll be able to tell whether there are a certain sort of high-risk areas within the hospital and high-risk professions within the healthcare workers who are more likely to be exposed.
Good deal. One more question, and I'll start, and then Dr. Bhatnagar, if you could conclude. The question is from the Courier Journal. How many participants are involved in phase 2 from the community, and how are you finding them? We do have a news release we issued last week, I believe, on phase 2 testing that I can share. If people will email me at jill.scoggins@louisville.edu, I can send you the news release. In the meantime, Dr. Bhatnagar, if you would talk about how many participants are involved in phase 2 and how we're finding them. Right.
So we set out to do this in a very systematic fashion, which was we wanted to get 2,400 participants from all over the town, with the uniform distribution from different areas within the city. We sent out over 12,000 letters of invitation signed by Dr. Neeli Vandaputi to invite people to come and participate in the study. We got a rather low response given what was and what is happening in our city. We got really sort of low response from with the West End and from South Louisville. And so then we opened the invitation up to people and advertised on the public media. We did, campaigns to reach out to people. People have their own private groups or sort of chat bots, so that we spread the word as much as we could to get people to participate. And we got an overwhelming response. I think we will exceed our target of 400. We would, I think, have more than 3,000 participants from different areas. And so we had to, in order to be more accessible, we had to open up a site up in the West End so that people don't have to drive downtown to get tested. And therefore, we believe that we would have a large and robust sample, though not entirely random by now, sample to be able to tell what the rates of infection and the antibodies are within our county.
Good deal. I'm not seeing any other questions. If someone has a question, please feel free to submit it. Also, this news conference will be archived on the U of L YouTube site. So if you want to follow up with anything and recheck something as you're working on your stories, feel free to do so. It will be on the University of Louisville channel on YouTube. So if there are no other questions, I thank everyone for joining us today. If you do have another question after we sign off here, feel free to contact me. Again, my cell number is 52650-2624, and we'll get the answer to you. Thank you very much, everyone. Thank you to our doctors, and thank you to everyone on the call. And with that, we will sign off.
Thank you.